Zoran Stankovic. El doctor viene desde Serbia. Él es jefe del Centro de Formación de la Federación Internacional de Ginecología Infanto-Juvenil. Es actual presidente de la Sociedad Europea de Ginecología Pediátrica y del Adolescente. Welcome, doctor.
Dear friends in Pediatric, Adolescent Gynecology, I'm really honored to be with you today, and thank you to Professor Anna Maria Ricaldi for her invitation and to give me a chance to be with you in these 3 days. And thank you for all of you who serve in Pediatric Adolescent Gynecology during your practice. I will try to speak about the future in present time. And we heard something about 3D now, after the violence, and we will try to go further, what is next, and I will use these references in my speech, and the last one was published 2 weeks ago, and please, if you want to read them, I can send you by email, but please ask me by email to send you the reference. I will share with you first our experience in Europe. How we, in few slides, I will share with you how we combined education process and how we changed the education process in Europe. The European Board of College of Obstetric Gynecology, EBCOG, is the European Continental Gynecology Association, which create all educations, and they published 10 years ago standard of care from women in the health in all Europe. And the chapter 11 was Pediatric Adolescent Gynecology. And hopefully they create the project of achieving consensus in training, and they recognize Europac as a partner to work together to create standardization of education process in pediatric adolescent gynecology in all European countries. And we create curriculum with the aim to standardize the knowledge between gynecologists, pediatricians, pediatric surgeons for the basic level, and you can understand that we used all of this in 16 different chapters. And in curriculum, we shared 2 parts, medical parts, and the other chapters are medical surgical parts. And everything is covered in pediatric adolescent gynecology, and when you saw this map, you understand that this is very multidisciplinary field, and I will always, we need to accept that this is multidisciplinary field of interest and that we need to work together. How we see really the education process. We need to keep the both levels, basic level, core level for all doctors, and advanced level for subspecialty. And I will give you 3 slides, no worries, with these items. How we managed the problem identification is the most important. The 2 options of diagnosis, without performance of specific skill or with performance of specific skill. Information is very important, indication of treatment is very important, and again, treatment can be different. And now you can see all of these in these 2 options. The first is basic level, and this is advanced level, and subspecialty level. How that really works in all of these 16 chapters is difficult without example. And because of that, I prepared these 5 steps for you with example, and of course I choose my favorite field of interest, ovarian preservation and ovarian lesions in pediatric adolescent gynecology, because ovarian lesions are the reasons of almost 85% of surgical treatment in pediatric adolescent gynecology, of course, we have so many colleagues involved in this. At least radiologists, surgeons, pediatricians, and pathologists and gynecologists. And we can start. How we are educated in ovarian lesions? We are educated that ovary can create so many problems. And we have headache when we learn this. And our teachers teach us to use ultrasonography and to share what we see in 3 different options: cystic, solid, or complex. Oh, okay, this is easier. And they said, be careful, maybe it is malignant. And I prepared the references between 2001 and 2016 with the most citation in the literature, and found that the usually percentage of malignancy is no more than 12%. And what we really want to preserve all ovaries from benign tumors, and all of us know that we can open the ovary, enucleate the tumor, and preserve whole ovary, and during laparoscopy or laparotomy, doesn't matter. And what we saw in the literature, we saw something strange. Gynecologists published, we are better than surgeon, and we preserve more percentage of ovaries than pediatric surgeons, but they don't explain in the articles based on what skills, surgical skills, or what is the knowledge of gynecologists that they create so many good things. And what we can see undoubtedly in these papers, they increase the level of laparoscopy in their groups, and they doubled unnecessary surgery for uncomplicated functional cyst. All of this is unnecessary surgery. And no citation about that. Nobody see. Can you believe that? Nobody see that that is a problem all over the world? What is this? I believe on fears-based medicine. That's the evidence. How we are learned to work. We are learned to manage the patients in next level. We can close our eyes and say, creo en el bien, creo el bien. Then we open the eyes, donde está el mal? My Spanish is better. Thank you to Salvador Dali. He gave us chance to see both options. You can see now first the elephants or first the swans, doesn't matter. Both are right, both are good. And we need to change our education process. How? We need to start with normal and always need to keep where is the normal. Normal ovary is small and the volume is 1 milliliter in premenarcheal girl, 3 milliliter in premenarcheal, 6 in adolescent. And the most common lesion is ovarian cyst. Inside the ovary, excellent. We can admire to the ovary surrounding the cyst, not to the cyst how interesting, complex picture can create. And we need to measure the volume, because the volume can explain us the difference, not only one diameter. You can see the difference between 3 and 8, 3 times, but the difference in the volume is so many that more than 30 times. And then think about what happened with normal ovarian tissue when volume increase. Simple. Normal ovarian tissue surrounding the tumor. Always. Benign tumor and cyst. And we can enucleate and preserve the ovary based on that. But how many times, really, in your practice, you see that your colleagues really examine and report the presence of normal ovarian tissue? What do you believe? The earth is plate, or like ovary is ellipsoid? Because if it is ellipsoid, we cannot see the horizon different than the plate. And in this case, with transabdominal, transvaginal probe, you can see only in one part of the image normal presence of ovarian tissue. And normal ovarian tissue is always present. Functional cyst, follicular cyst, corpus luteum cyst. Endometriosis, and the most common benign tumors, matroteratomas. Please come afternoon to see more about matroteratomas in the next lecture. And cystadenomas. And horrible. In this case, 8 centimeters cyst. Who knows what is inside? They manage annexectomy, my friends. Okay, this was 20 years ago, but this happened. And this adolescent lost the ovary to show, and I take a picture because that moment I didn't know how to stop to manage this operation. Now I know, because even in this old equipment, you can see the presence of normal ovarian tissue. And you can say, stop, or you need to go expectant management. Can you really create cystectomy in functional cyst? If anybody say yes, don't believe him. It's not possible. You can't create cystectomy in one row of cuboid cell. I never did. I never see that. Always damaged. And what we published in literature, we increased the ovarian preservation based on this knowledge for benign tumors and torsions, and decreased unnecessary surgery. How? Based on 3 rules. We published in 2017 3 rules based on the volume and the structure of the tumor, and of course of the presence of normal ovarian tissue. The first rule, how to escape from unnecessary surgery. Second rule, how to recognize torsion and to keep ovaries. And third, how to recognize benign and keep ovaries. And who is very near to us? You can see our system. Wow, excellent. They start to draw, radiologists start to draw normal ovarian tissue. Excellent. Oh no. They don't ask to report, to visualize, even in ultrasound or in MRI. But who can teach them? All of us. We need to say to them, please, this is the most important sign for us. We believe in good. We believe in ovary. Give us information. How it looks like, for example, in those, I will show you only this case. It is 2 kilograms tumor, solid tumor in the ovary. This is normal tissue surrounding the ovary. And you can enucleate the tumor. And now, please, give a freedom to your mind and believe your eyes. And you will see normal ovarian tissue. You don't need to have any ultrasound skills before today. And you can see. The bladder, adolescent, not sexual active. Wow, solid tumor appear. Solid tumor appear, solid tumor appear. And now you can start to see normal tissue. Wow, excellent. Normal tissue is there. You can see the final image. Normal tissue surrounding, and you saw in operation, we opened and enucleated the tumor. We believe in good. What we saw in the literature by colleagues from Canada, they start to retrospectively investigate their photos, and they try to use ovarian crescent sign as in retrospective study and show, no, in many images they don't found presence of normal tissue. Why? Because image is focus on the tumor, not on the presence of normal tissue. You saw that. In many images, no presence of tissue. And then you see, okay, you don't believe me. One more case. Video, 16 seconds. This is complex small tumor, transvaginal ultrasound, more easier than transabdominal. And you can see 4 centimeters tumor in the ovary. Where is the ovary? No ovary. No ovary. No ovary. Where is normal tissue? Never. You never know. You can see now. Yes, increase. Increase the normal ovary. You can see the normal ovary. If you change the angle, what you can see? Corpus luteum in that part of ovary. Oh, tumor disappear. No, this is not disappear. We operate this tumor because we are suspicious for borderline, and we enucleate the tumor and keep that ovary. This was borderline young patient. And don't worry. In all patients with invasive malignant tumors, ovarian tumors, in pediatric adolescent age, you can see presence of normal tissue. That was Germanova, Yolk-Sac, and the other invasive malignant tumors. Non-invasive malignant tumors, juvenile growth cell, we speak this morning about them, and you can ask in discussion later, but in the most of cases, in adolescents, normal tissue not exist. And what is the most important in our practice? Torsions, because 1/3 or more percentage of really surgical treated are torsions. And now it's simple for your eyes. What you can expect if solid tumor with torsion exists there? The ovarian edema. Normal ovarian tissue become ovarian edema. And then you can recognize, of course, you have clinical symptoms, and you can see the ultrasound and say, okay, this is benign lesions, but this is torsion. We need to treat this as fast as possible. But the most frequent is normal ovary, torquid without cystic tumor. And now if we use both, first the volume, we can see the difference between left and right ovary. And please don't tell anything that this is solid tumor, this is not solid tumor, this is blood in the ovary, and this is torquid ovary, and now your eyes very easily can recognize torquid ovary, normal ovary, and it's not solid. And what I found in literature for you, I read yesterday because of you, I found in the hall 4 books of ultrasonography in Spanish, and all 3 of them were in obstetricia and gynecologica. I found only this one with gynecological part chapter. And wow, can you believe one chapter with 14 pages, pediatric adolescent ultrasonography. And okay, in some of images in the book you can see presence of normal tissue. The author didn't write about normal tissue, but he put in the book 1, 2, 3, 4, 5 benign tumors, and all images are focused on tumor. Where is the normal tissue? Okay, I hope that you will inform now our colleagues, radiologist, pediatrician, pathologist, surgeon, and gynecologist for adult, to understand that if ultrasonography report is without volume of ovary, it's incomplete and unuseful. And if increase the ovarian volume, need to be presence of normal tissue or the absence of normal tissue in the presence of edema. And then we can teach that what is different levels. If you cannot see normal tissue, if you cannot see edema, please send that patient to pediatric adolescent gynecology. It's not for you. I hope that you agree with me that we need to keep the future and the presence of pediatric adolescent gynecology as a multidisciplinary field in all of these 16 chapters. And sorry because I focused in my favorite chapter. And thank you with the flowers for my garden.
Bien, muchísimas gracias, doctor Sora. A continuación vamos a pasar a las preguntas. Si tienen alguna duda, acá están los expertos para responder sus dudas. Bien. A continuación vamos a entregar los certificados por su participación a los doctores en este simposio.